Hi, everyone. Thank you for joining me today. It is my pleasure to welcome Dr. Rob Fitzgerald. Rob is a professor of pathology at the University of California, San Diego. And Rob also has his own YouTube channel, which is worth checking out if you're interested in learning about it's called Quick Hits in Laboratory Medicine. And you can search it by looking up Robert Fitzgerald, Clinical Chemistry. And that channel also has an associated textbook called Clinical Chemistry, a practical learning and teaching toolkit. And I highly recommend you check those out if you're interested in learning more about the field. But Rob, thank you for joining me today to have this discussion about laboratory medicine, biomarkers, and other interesting things that you've been working on.
Thanks, Joe. It's a pleasure to be here. The gorgeous spring day outside and the cherry blossoms in bloom. New Haven's a gorgeous spot.
Thank you. Pleasure having you. And the first topic we wanted to discuss is your recent work focusing on cannabis and assessing driving under the influence of cannabis and our ability to tell people who have smoked cannabis and how it impairs their driving and how well we're able to do that using current tools. So I'm curious in terms of how big of a problem is this for the country? And what have you learned from the studies that you've done so far?
How many hours do we have? So it's a difficult problem, and it's, we think about driving under the influence of alcohol, which we understand reasonably well, and we know the risk, that how bad it is to be drinking and driving. The science behind cannabis and driving is much less well developed, and it's a much more difficult task because of the kinetics of THC relative to ethanol.
No, yeah. So, I'm curious, especially given what we know with alcohol. Typically, people, for example, they talk about the 0.08 cutoff that we used to say somebody is definitely cannot drive and is considered guilty for driving under the influence with a specific cutoff. So you're saying that it does not work as effectively with cannabis, right? But yet we know there are states who have some laws that say that if you're above a certain concentration in your blood, you're guilty. Can you comment on what are your thoughts on that and how well that works?
Yeah, so I think I didn't answer your first question very well, so I'd like to do that. The relationship between alcohol and driving is sort of an exponential one, where if you're at a 0.05, I think you're twice as likely to be involved in an accident. But if you're at a 0.08, you're 4 times. And if you're at a 0.15, you're at 15 times. So the relationship between blood alcohol and adverse effects on driving is exponential. And I think for THC, it clearly is impairing. We don't know the full impact on society as legalization has happened, but it's not as impairing as alcohol. And I don't think that it's has that log relationship. Maybe you're twice as likely if you're using cannabis to be involved in an accident, but it doesn't go out to the 15 or it's just not as impairing as alcohol. So.
And to that point, yet you have, as we know, some states that have enacted regulations surrounding this. And I'm curious, where should they, in a scientifically driven country, where, would we say, how do we feel about those limits given what the studies have shown and what you've discussed? Because I think you mentioned there's they call them per se limits at 2 and 5 nanogram per mil.
Yep. So per se is a presumption of being guilty based on a single measurement and really doesn't relate to actual impairment. It's a societal decision that we have made for alcohol. At a 0.08, you are per se impaired, and it's illegal to be driving with the blood alcohol content of that. With THC, some states have tried to, quote, simplify things by having a per se, and it doesn't work very well because the relationship between blood concentrations of THC and performance are not, it's essentially, if you look at the data objectively, there's no relationship between blood THC and effects. which is kind of shocking, but it's true.
Yeah, and so given that, I'm wondering, would you consider that should states revise those per se limits based on the findings that you've had?
So I think that we have a judicial system where there's an adversarial and you have a chance to defend yourself. And I think that there's good data that you can use to defend yourself, that simply having a measurable amount of THC in your bloodstream doesn't mean that you're impaired.
That's fair and good to know. And then from the perspective of looking at the causes of that, do we understand why there's differences in these, like between THC and alcohol? What are the driving factors behind why it's not as impairing if you have a low or a higher level of THC versus an alcohol? It clearly is exponential in correlation. Are there factors that predispose you to have higher levels versus other people but you're still fine?
Yeah, there's certainly some tolerance with cannabis. I think that the pharmacological mechanism of action is just way different, and the lipophilicity of THC makes it a lot harder to draw conclusions based on simply concentrations.
And is that because essentially, like in the case of lipophilicity, that's because it's stored in adipose tissue, so in fat cells, and you could have releases over extended periods of time. And I know, like from at least urine testing, we know that in some people who are chronic users, you could end up with detectable levels weeks out, whereas with new users or naive users, that's usually only a matter of days. So it sounds like at least the story of THC and driving under the influence is a lot more complicated than alcohol.
Absolutely, yep.
Are there any recommendations from the perspective? I know you've tested blood, oral fluid, breath in your studies. Did you find that was one better than the others in terms of helping define use that could lead to driving under the influence?
Yeah, that's a good question. It comes down to kinetics and how fast is it cleared and does it have any relationship with recency of use? And our studies have showed that probably oral fluid gives a window of detection that's maybe most useful. Blood, it can be detected for weeks, and clearly people aren't impaired for weeks, whereas oral fluid is cleared a bit faster than that.
And it sounds like this is still a new area of study, and a lot of this we still need to better understand, do more studies. But your study is noteworthy because it is the largest of its kind that has looked at this in 190 some individuals, whereas most other studies looked at a few. So it's nice to see this develop an understanding of, hey, it may not be as simple as you think with these cutoffs, and you can't simply assume somebody is impaired driver because they have detectable THC in their blood. But it doesn't sound like THC is an ideal biomarker, so to speak, for this. So can you comment, what would be an ideal biomarker? What would that look like?
So that sort of depends. If you're talking about traditionally biomarkers, I think about them as being more chemistry related. A biomarker for impairment, I think we're a long ways from that. But there are other biomarkers that we use in clinical medicine, and some of them, my definition of a successful biomarker is one that improves patient care.
And along those lines, because I know you've essentially had the latter of your career focused on toxicology, and can you think of like other biomarkers that you've worked with earlier on in your career and how those have helped patient care?
Yeah, for sure. When I started my career, I was a toxicologist, and I realized to be a good toxicologist, I needed to learn clinical chemistry. And so I started learning clinical chemistry, and it was actually a sales rep came up and said that they had this new biomarker, and I didn't really even know what a biomarker was, that was going to change how we diagnose myocardial infarctions. And she gave me some of the background, and we started doing studies with it, and it was troponin. And I've seen that evolve. That was what we called Gen 1 troponin. We are now on the 5th generation, and there's probably more coming. And
from that regard, at least troponin is one we regard as an almost ideal biomarker, given its performance and how well it detects acute myocardial infarctions. I'm curious if you've encountered other biomarkers that were maybe not as good for the purpose, or that looked ideal and then performance showed others, and what are some of the lessons learned there?
Yeah, interesting. When troponin first came out, I was a fledgling toxicologist and didn't really have any credentials in clinical chemistry. And I was talking to our cardiologist, and they were saying that the data that I was showing them was too sensitive. So it didn't start out as an ideal biomarker, and they were calling things false positives. One of our residents published a paper looking at, elevated troponins in renal failure. And at the time, they were termed false positives, but that patient population has a high prevalence of cardiovascular disease, and we were really picking up true positives. We just didn't know it. And so the biomarker evolved, and it actually changed practice. And so cardiology evolved because of the biomarker, and that's been a really powerful story for laboratory medicine.
No, absolutely. And sometimes we struggle because the current approach, is always what you're evaluating new approaches against. And in this case, I'm assuming they were testing CKMB and noticing that it was negative. But with troponin being more sensitive, you're essentially picking up these things sooner or more sensitively than CKMB. And so seeing that, and now seeing new biomarkers come out on the market, like now we're looking at Alzheimer's and others, I'm curious if there's a lesson learned there. And like as biomarkers come out, there's sometimes studies showing amazing performance, and in the case of troponin, deservedly so, that's a success story, right? And I'm wondering if there are examples of biomarkers where you've seen that maybe were promising, but ended up not being what they were promised to be because of other studies that have shown truly that there is a lot of false positives, false negatives.
Yes, I think one of the issues with validation studies is that sometimes the population in a trial is different than the population in a routine hospital. And so it's really essential that you test it in the patients that it's being used and show that it works. And so some biomarkers that probably are good biomarkers don't perform well in the clinic because the patient population is maybe not correct. And so a good example of that, in my view, is procalcitonin. I think procalcitonin does tell us a lot about upper respiratory tract infections, and if it's used properly, it can benefit patients. But it's not always, and there's a lot of data showing that in the real world it doesn't get used as well. So the clinical trials show that it's powerful, and certainly antimicrobial stewardship is a big deal, and we need to do a better job with that, and potentially PCT can still do that. Maybe it will evolve like the troponins.
Yeah, and I guess the lesson here is it sounds like if a biomarker, then use of it becomes sort of off-label, so to speak, where you start implementing it without this specific understanding for the general population, it ends up being less useful. So that's very helpful in terms of recognizing in our field that sometimes our intended use for a test, especially when it comes out, may evolve over time, and that evolution may not always be for the better performance of the biomarker.
There you go. So, yeah, hopefully, I think that's one of our responsibilities as laboratory directors is to help guide that and, test the right patient population. But it's sometimes hard.
And finally, if there's any advice you would give yourself back when you first entered the field of clinical chemistry and laboratory medicine, is there anything you can think of that would be helpful for trainees, people trying to get into the field, that would be helpful to them as well at this stage?
I think one of the big things that I was not good at initially was getting out of the lab and meeting clinicians in their office and talking about laboratory testing and how they were using it and what were the limitations. Building those relationships is really important for patient care and for advancing science. No,
that is very valuable advice. And I'll say, from my perspective, having learned that as well, opens up doors for research projects, open up so many doors like business plan type agreements and approvals. So appreciate you sharing your perspective. And again, thank you for this wonderful discussion on biomarkers and the work that you've done with THC for the benefit of the country.
Well,
thank you so much. Appreciate it.
Pleasure to be here. Appreciate it.
Thank you all for watching.